Sure.
Good evening, everyone present here. I am Faraz from Clarinet. Clarinet is very proud to be a part of this session as a digital partner. Clarinet is India's digital live CME and doctor-generated learning platform. With all of you, I am presenting a short video on Clarinet. Thank you so much all doctors for watching the video. And you all are requested to visit our website www.clarinet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. We have MedWiki services, which is medical Wikipedia for doctors only, that you can also read. Now I would like to hand over this session to Dr. Ashima Malhotra ma'am. Ma'am is senior consultant and head of department critical care and anesthesiology, Siddh Hospital, Muradabad, Uttar Pradesh. Over to you, ma'am. Kindly proceed from here.
Good evening, everyone, and welcome to this beautiful Saturday evening. We celebrate international days to mark the important aspects of the human life and history. Since 2016, we are celebrating 5th September as the Spinal Cord Injury Day with the intention of increasing awareness among the general public. Spinal cord injury and resultant paralysis has devastating physical, mental, social, and vocational consequences for the injured. Cervical spine trauma is a common problem with a wide range of severity from minor ligamentous injury to complex osteoligamentous instability. The evaluation of the patients at risk of cervical injury relies on the standardized clinical and radiographic protocols to identify the injuries, associated pathologies, classify injuries, and predict instability, treatment, and outcomes. Let us all welcome our esteemed speaker, Dr. Gunjan Paul, who is Associate Professor Critical Care Medicine at Dayanand Medical College and Hospital, Ludhiana. Over to Dr. Gunjan Paul for this first lecture in the series, which is about the evaluation of the cervical spine injury. What's new? Over to you, Dr. Gunjan.
Thank you, ma'am, for the kind introduction. And I will request Farhaz to play the video, please.
Yes, ma'am.
Good evening, everybody. At the outset, I would like to thank SNCC for giving me an opportunity to be a part of this prestigious platform. We are all here today to commemorate the World Spine Injury Day. Why is spinal cord injury so important? Because despite existing preventive measures, it has been showing an increasing trend. Spinal cord injuries have increased 2 to 2.5-fold in the last 2 decades. The world data shows that cervical spinal cord injuries contribute to about 40% patients of total cord injuries, while a retrospective study from Northeast India showed that more than 50% patients admitted to the hospital with spinal cord injuries had cervical spinal cord involvement. And the alarming situation is that it affects the young males, that is the most productive youth population of the nation is being affected, although the world data shows that it has a bimodal trend. Prevention of spinal injury must be the aim because the disability from spinal cord injury has devastating effects not only on the society but also on the patient in terms of continued care even after discharge. And cervical spinal cord injury has the highest mortality among all spinal injuries to the tune of 60%, especially in the elderly population. Although the prevalence of cervical spinal injury in all trauma patients is less, but the impact is huge. And you can see that it has about 8 times more patients are affected in the low middle income countries as compared to the higher income countries. Based on current evidence, there are 3 major mechanisms. The road traffic accidents or the motor vehicle accidents contribute the major mechanism in the low middle income countries, whilst falls, which are associated with sports, occur more commonly in the developed world. In the developing world like ours, it is a personal experience that we commonly face patients every once 2 to 3 months, there is a patient admitted who was working on the electric pole, got an electric shock, had cervical spine injury and rhabdomyolysis. So injury associated work is more common in developing countries, showing lack of preventive strategies. There are certain risk factors associated with cervical spinal cord injury. That is, a pelvic fracture has a significantly independent association with cervical spine injury. It increases its risk 9 times. Head injury with pelvic fracture and a fall from a motor vehicle accident increases the risk of cervical spinal cord injury 15 times. The knowledge of these risk factors is important because it merits further monitoring and increases the pre-test probability of diagnostic tests. Before moving further, I would just like to discuss about the classification of cervical spinal cord injuries. Historically, many classifications have been proposed for spinal trauma, but they lack clinical integration and do not have inter-observer variability. So the AO Spine Knowledge Forum tried to develop a comprehensive and easy to use clinical classification, unifying all the existing classification. And in this classification, the cervical spine has been divided into upper cervical spine and the subaxial spine. Because of its unique osseous and ligamentous anatomy, which not only gives it a wide range of movement, but also makes it more prone to injury because it is not protected in the thoracic cavity. The injury is more common at C2 level or at C5 and C7 level. That is at both the points where it is attached either to the head or to the body. So the first component of it includes the morphological element, and in it there are 3 categories, each category including the bony element and the joint caudal to it. Like the category 1 includes the occipital condyle and the craniocervical junction, category 2 C1 ring and C12 joint, and then C2 and C23 joint. Each category is further divided into A, B and C categories. The type A includes isolated bony injury without any ligamentous injury. They are usually stable injuries and have conservative management. Type B includes ligamentous or tension band injuries with or without any bony injury. And type C include transitional injuries, and they involve the separation of anatomical integrity, and they are usually unstable and they require surgical management. The second important component to this classification is the neurological involvement, denoted by the letter capital N. N0 means the patient is neurologically intact, and this neurological examination is done initially when the patient arrives in the emergency room. N1 through N4 involve transient to complete spinal cord injury, and next when you are not able to examine the patient, and N plus means the presence of a clinical modifier. This third element of clinical modifiers is unique to this classification, denoted by the letter capital M, which are they're different for cervical spine and for subaxial spine. They're not related to the severity of the injury. More than one clinical modifier can be present in each case, and their case-specific characteristics will decide about the treatment, and they also affect the outcome of the patient. Like M3 means patient has high risk, he is elderly, he has comorbidities and bone disease, which might affect the person's decision for a surgical treatment. The subaxial spine is again divided into 3 categories. A include compression injuries, B tension band injuries, and C translational injuries. And the unique to this subcategory is the facet dislocations, because of the axial alignment, very less force is required for subaxial facet dislocation as compared to the dorsal and the lumbar spine. This classification has good inter and intra-observer reliability. The second reason why we are here today is that despite many algorithms, recommendations, and guidelines in place, there are many gray areas in the evaluation of cervical spine injury patients. There is no definite consensus for some questions like who should be evaluated for traumatic cervical spine, who needs radiological assessment before cervical collar, and there are a few list of questions which we will be answering in the next few minutes. The ATLS and the pre-hospital trauma life support guidelines uniformly recommend immobilization as a priority procedure in the pre-hospital stage for all trauma patients, unless and until proven otherwise. And most of the emergency medical services, they imply the triple immobilization, that is hard cervical collar, spinal backboard with blocks and tapes and straps to immobilize the entire patient. But as complete immobilization is not possible, the term spinal motion restriction is a better terminology to designate procedures which are in place for stabilization for the spine, because about 1/4 of the spinal cord injuries occur during transit. Our main aim is to prevent possible pathological motion of the injured spine during transport to prevent any further neurological deterioration. So is it that all patients require SMR? Because in recent years, there has this practice of uniform application of cervical collar has become a matter of debate because of the growing body of evidence of the inherent complications of the cervical collar. It is worthwhile commenting here that an inappropriately applied collar may just give a false sense of security. Spinal motion may still be possible, and it may actually exacerbate the injuries. Because of the presence of the collar, mouth opening is not possible, and it increases the risk of aspiration. Because the collar can cause venous obstruction, it increases the ICP 3 to 5 millimeters. How much it is clinical significant is not known yet. The collar also has an effect on the airway management, and in the presence of a collar, an underlying hematoma may go unexpanded and may be unnoticed. So in penetrating trauma, it can actually increase the risk of mortality. If left in place for long, it also causes pain, and there is increased risk of pressure ulcers. 66% increase has been documented with each passing day. Also, there are logistic issues that it can lead to prolonged pre-hospital on-scene time and increased difficulty in the clinical examination when the patient arrives in the emergency. So based on this, that in light of probable hazards of the immobilization and low risk to awake asymptomatic patients who have stable neck and neck position and can maintain neck position well, it is recommended by the World Federation of Neurosciences Spine Committee that awake asymptomatic patients should not arbitrarily or routinely placed on cervical collar. It also strongly recommends against spinal stabilization in patients with isolated penetrating injuries. It is clear that if the patient has altered sensorium, if there is spinal tenderness, spinal bony deformity, or sensory and motor deficits, stabilization should be done. But it is a good clinical practice to use triaging tools in other patients to determine whether it should be given or not and how it should be performed. So once the patient arrives in the emergency, who are the patients who should have imaging performed? Because routine clinical examination cannot detect all cases of secondary spinal injury or unnoticed injury. So the two most common triaging tools which are evidence based on multicentric trials and have been validated are the NEXUS rule, that is National Emergency X-ray Utilization Study, which is recommended by the American Association of Neurosurgeons and Congress of Neurosurgeons and the EAST guidelines, while the NICE guidelines recommend the Canadian C-spine rule. These rules are hardly comparable because the NEXUS includes a set of question answers answered in yes or no, and the cervical spine rule involves an algorithm of sequential steps which must be progressively followed. So there are 5 criteria which make the patient suspicious for cervical spine injury, and all of them must be followed for low probability of cervical spine injury. That is, there should be no focal neurological deficit, no midline spinal tenderness, no altered level of sensorium, no intoxication, and no distracting injuries. In altered level of consciousness, it is in GCS less than 14. If the patient is not oriented to time, place, and person, patient cannot remember 3 things at 5 minutes, or there is delayed response to external stimuli. However, loss of consciousness at site does not preclude the application of the NEXUS rule. If the intoxication is present, wait and watch technique can be followed till the patient becomes cooperative enough to participate in the cervical examination. Distracting injuries include long bone injuries, visceral injuries, severe burns, or degloving injuries. If all of them are absent, then the cervical spine can be cleared clinically. It has a high sensitivity and high negative predictive value while low specificity. That is, still there may be many patients who are unnecessarily exposed to radiation. While the Canadian spinal rule it also requires the patient to be alert and awake. For this rule to be applicable, it includes 3 high-risk factors. First is age more than 65 years, dangerous mechanism, which include high-speed motor vehicle accident, death of the co-passenger, fall from height more than 10 feet, vehicle rollover, or ejection or fall from the vehicle, and presence of paresthesias. If any of the high-risk factor is present, patient needs radiography. If high-risk factors are absent, then we proceed to assess for the low-risk factors. If no low-risk factor is present, then they are not at low risk and they require radiography. If one of them is present, then we can proceed for the examination. Patient can be assessed for pain with a 45-degree active range of movements. And if the patient can perform these movements with or regardless of the pain, radiography is not required. So the patient can be cleared clinically. It also has high sensitivity and specificity, and negative predictive value is not reported. But both these, for the application of both these rules, patient should be alert and active. It is not applicable to pediatric patients. These rules were developed to decrease the cost associated with radiography and unnecessary exposure. But because they have low specificity, if we miss one patient with Canadian spinal rule, there's a chance of missing 16 patients with the Nexus rule. So rather than applying either, it is recommended that we apply both of them in our clinical practice. The next question is, if imaging is decided, what is the initial best choice of imaging? High quality, that is a 64 slice or a higher CT, is the first choice of imaging investigation because it has better sensitivity than the X-rays, 98% versus 52%. Only and only if high quality CT is not available, only then plain radiography. Otherwise, plain radiography is out of the picture nowadays. If radiography is done, it should be supplemented with CT whenever available, and complete occiput to T1 exposure should be done. It is a strong recommendation. It is also recommended that the CT should be obtained as soon as possible and should be read by a qualified radiologist. And if in case of acute traumatic spine injury, patient should be transported to a definitive center as soon as possible, not more later than 48 hours. We know that CT is an ideal modality for examining bony injuries and cannot pick up occult ligamentous injuries. So what kind of imaging should be done in an obtunded patient? Because in blunt trauma patients without reliable clinical examination, they are at increased risk of occult cervical spine injuries, and a negative CT, the risk of cervical insult is small but not zero. So based on these, initially 2 out of 3 rule was followed, that if CT is negative, either the patient should be clinically examined, wait till the patient becomes awake and responsible for clinical examination, or shift the patient to a soft collar till the MRI is obtained. And if the CT is suggestive of ligamentous injuries like dislocations and subluxations, MRI should be done. But the problem with MRI is that even if MRI shows ligamentous injuries, they represent laxity of the joint, that it can impinge upon the cord. It is just a surrogate marker of possible pathological injury. It may not actually translate into true cervical disability. And the best MRI is obtained within 48 hours. So based on this, recent evidence has changed the concept that a high quality multiplanar reconstruction CT, if it does not demonstrate any fractures, the negative predictive value of a clinical significant ligament injury is nearly 100%, and adjunctive imaging is not required. Despite the nearly safe cervical spinal collar removal after a multiplanar CT, there are high stakes, high responsibility of the physician, the cost involved in the MRI, the care of the patient in the presence of the MRI. So considering all these questions in the scenario, it is recommended that multidisciplinary consensus by a qualified radiologist, a spine surgeon, and an intensivist in rereading the images and then establishing whether a complementary MRI is required or not. If neck pain persists even after a negative CT scan, this is the most poorly answered and studied question in all the guidelines. Pain may persist because of muscle spasm and edema and may not necessarily indicate injury. So it is the recommended protocol is similar to obtunded patients, that is retain the cervical collar and do a complementary imaging, but the possibility of a dynamic radiograph is also added. If an MRI is done, it is short T inversion recovery sequence because it is a fat suppressed image and delineates the soft tissue bed. In case of persistent or delayed neck pain, it is better treated with early immobilization and physiotherapy rather than a soft collar. We've been talking about neurological examination. I would just like to mention it is done using the Asia Injury Scale, which involves the examination of the 10 key motor units, examination of sensory segments with light touch and with pinprick, examination of the all the deep tendon reflexes, digital rectal examination, and the planters. As an intensivist, the evaluation of the patient is not complete if I do not talk about the airway, breathing and circulation, ABC of the patient. So just a few points. Mask ventilation has to be done cautiously because it can cause more movement of the spine as compared to direct laryngoscopy and even fiber optic intubation. And because of the presence of the collar, the inter-incisor distance decreases to almost about 50%. So removal of the anterior portion of the collar should be encouraged before attempting intubation. Oral tracheal intubation with rapid sequence intubation should be done with manual inline stabilization because the extension of the spine does not occur during blade insertion but during blade elevation, so it can be prevented by inline stabilization, and it should be done by the most experienced provider. Direct laryngoscopy is what is endorsed by the ATLS irrespective of the type of the blade used. Video laryngoscopy can increase your first successful attempts at intubation, although the time required may be slightly more. You have to be cautious when you use an LMA for such patients because it might exert high pressure not only during insertion but also during inflation and while it is in situ. The other methods to deal with the difficult intubation may be fiber optic intubation or an urgent tracheostomy because cervical spine injuries can pose a difficult intubation. There are multiple studies in literature on different modes of endotracheal intubation in these patients, although they are limited by the fact that they have been done on small number of patients and they are retrospective, but they conclude that neurological deterioration is uncommon in cervical spine injury patients only after airway management. Although there are many confounding factors which have been acknowledged by the authors themselves, still if we apply these minimum precautions, we are unlikely to cause further neurological deterioration, at least during airway management. High cord involvement can lead to cessation of breathing altogether and may require an immediate intervention. Respiratory compromise is common in the early first week because of the secondary to ascending edema and may be the principal cause of death in such patients. They are candidates for early tracheostomy because of the damage to the cervical cord. There is paradoxical respiration and impaired cough, and tracheostomy may help in pulmonary clearance. We are regularly doing percutaneous tracheostomy in our ICU in the cervical spinal cord injury patients without performing neck extension with the help of either ultrasound or fiber optic bronchoscopy. Because of damage to the sympathetic chain and unopposed vagal activity, these patients can go into vasodilatory distributive shock. So a slightly higher mean arterial pressure must be maintained initially, and hypoxia and hypotension are the two things which must be avoided to prevent any secondary neurological damage. Fluids remain the initial choice of therapy as compared to vasopressors because they can cause additional ischemic loss to other injured tissues. While I was preparing for this talk, I came across this study that is point of care ultrasound was used to identify cervical spine injury. They could identify vertebral body fractures and listhesis, but the rate of missed injuries was high. So that is a learning curve is there for everything. So ultrasound might become a screening or a diagnostic tool for decision making in cervical spine injury in near future. So I will conclude by saying that triple immobilization of high-risk patients of spinal cord injury must be done during the pre-hospital setting. When the patient arrives, follow either the Nexus or the Canadian cervical spine rule or both to determine who needs imaging. If imaging is indicated, immobilization with the cervical collar should be continued. Prompt imaging with CT is preferred, high quality CT, and it should be preferably reported by a radiologist. In children or when CT is unavailable, only then plain X-ray should be done. Dynamic X-ray imaging is out of the picture these days. In obtunded patients, collar removal after negative high quality CT scan can be done. It does not require an MRI every time, but in suspicious cases, a multidisciplinary approach followed is a better technique. Symptomatic patients with normal CT scan must proceed to an MRI, and if there is neurological deficit or abnormal CT findings, the patient must be transferred to a definite center for advanced trauma care. Thank you.
Thanks, Dr. Gunshin, for such a comprehensive, for tackling this topic so nicely. Now we'll move on to the next topic, that is spine perfusion and cord protection. I invite Dr. Ajay Prasad Rishi to please take over. Dr. Ajay Prasad is an additional professor, neuroanesthesia and critical care at Sri Chitra Institute, Tiruvananthapuram. Over to you, Dr. Rishi. Dr. Gunchan, we don't have any questions. So we'll wait for the questions, and if there are any questions, we'll be taking the questions at the end of the session. Right now, we don't have any questions in the chat box for you.
Okay, ma'am.
Good evening, everyone. Warm greetings from Sri Chitra Institute, Trivandrum. On the outset, I would like to thank the Society of Neurocritical Care India for giving me this opportunity on the SCI day. So I'll straight away go ahead with the topic, that is spine perfusion and cord protection. So as already been discussed before, the worldwide incidence of traumatic spinal cord injury is going on up, and it has reached 23 million as of 2021. And the estimated lifetime cost of caring for a patient with severe cervical traumatic spinal cord injury is estimated at $1.4 million, excluding the loss of income. So it's met with a lot of morbidity as well as economic morbidity. And as of now, currently there is no treatment which has been proven to improve the outcome. So there's something like targeted perfusion therapy, which is an all concept which is being explored, that may improve the clinical outcome of these patients. So I'm sure all of us know about this, that whenever there is a traumatic spinal cord injury, there's a primary injury, which is a primary mechanical insult to the spinal cord, and followed by a secondary injury, which is a combination of vascular as well as free radical induced, excitotoxicity induced, and inflammatory mediated responses. So as intensivists and anesthesiologists, our concern is to limit the secondary injury so as to salvage the rest of the spinal cord, which has not been injured by the primary injury. So the treatment for spinal cord injury still, I mean, there is a set protocol, but there are a lot of things which are still arbitrary. So as already been discussed, it's mainly ABC. And the blood pressure management, there is a no to steroids as of now because it's not supported by evidence. And the imaging as well as a lot of things which go with it. However, most of the guidelines are quite arbitrary when it comes to blood pressure targets and how to guide for how long we should maintain the targets. All these things still remain unclear. The only one thing which has a clear-cut level A evidence is that there should be early surgical intervention if there is an unstable spine, as well as if it's an open thing, you need to do open reduction. The European as well as UK, the guidelines, there is no consensus on the blood pressure targets, especially what target to be kept and for how long. However, the American societies, they have a joint guidelines which has mandated to keep the NAP at around 85 to 90 millimeters of mercury for the first week following a traumatic spinal cord injury. So this is a study which was done by Matthew Gallagher. He actually used laser spectral contrast imaging in patients who were presenting with acute spinal cord injury for surgical decompression, laminectomy, as well as for fixation. So based on this LSI imaging, they quantified the blood flow in the spinal cord post laminectomy. And as you can see, there are arbitrary color-coded scales, wherein which the blue and the darkish blue is like nearly absolutely no flow, whereas green to yellow is like moderate flow, and the red is like high flow. So based on this, they studied the blood flow characteristics in these patients who presented with spinal cord injury. The results which they obtained were like, as expected, there are 3 zones in a traumatized spinal cord. That is the area of impact which has a necrotic or an ischemic sender core, where the primary insult has happened, where there is absolutely very little flow, as you can see here, as denoted by dark blue and light blue shades. And then there is a penumbra, ischemic penumbra, where there is moderate and in the patchy blood flow, and there is a normal cord beyond that. And what they found is when they tried with the LSI, that when the mean arterial pressure, when it fell below 70, you can see that here you can see three rows. The green is the one which signifies the zone 3, that is the necrotic area. There is no change in the blood flow across the blood pressures because already the area is ischemic and there is absolutely nothing there which requires a blood flow. There's no metabolism, nothing happening. Then the red is the zone 2, which is the penumbra region. And if you can see there, below 70 millimeters of MAP, there's a sudden drastic fall in the blood flow as quantified by LSI. And beyond that is a zone 1, which is a normal area where there is an intact autoregulation. And you can see even below MAP of 70, the blood flow is being maintained. However, in the penumbric region, the autoregulation is not intact. So it's pressure dependent, pressure driven. So below a MAP of 70, they found that there is a drastic flow. So then they kind of went ahead and they found like certain interesting parameters which happened. That is something called as blood pressure induced local steal. So this is a scenario wherein which, so we all thought like augmenting the blood pressure is always good for the spinal cord. But what they found was quite interesting. That is, if you see the cord, this is the image of the patient who is having a cervical, thoracic level, upper thoracic level of injury. And you can see that the post-laminectomy cord is quite edematous. And at the higher MAP of around 105 versus a MAP of 89. So you can see that, of course, there is an area of necrosis and ischemia here. And followed by, there is a penumbral region. And you can see that it is receiving quite a good flow as denoted by the arbitrary units in by LSI. However, when they augmented the blood pressure to 105, what they found was the blood pressure actually surprisingly it reduced. So this was quite baffling for the investigators as well. And throughout, when they compared between the two, they found that there is a decreased perfusion in certain areas at a higher MAP. So what they took was when there is an increase in the absence of an autoregulation, especially when we are trying to increase the blood pressure beyond a certain level, especially with pharmacological agents like noradrenaline, what they found was the noradrenaline is actually causing reduction, vasoconstriction and reduction of blood flow beyond a particular level at the areas which is being perfused. And also what they found is, so that is like kind of driving the blood away from the penumbra region to the other normal spinal cord levels. And another phenomena which they found, which was quite different and quite different compared to the cerebral blood flow, was the diastolic ischemia. So here you can see again another patient who is having a thoracic level injury. And post-laminectomy, when they did the laser spectral imaging, what they found is they found there is a cyclical change in the blood flow, the systolic versus the diastolic. So as you can see here, the systole, it's quite nicely perfused, and there are certain areas with a patchy perfusion compared to diastole, where the pressures are around, diastolic pressures around 50 millimeters of mercury. You can see that the blood flow is relatively less, especially in the penumbric zone. And certain areas, as you can see, is perfused only in systole. That is represented in the green in the entire cardiac cycle. This is the image of perfusion in the cardiac cycle. So certain areas were perfused only in systole, which shows that there is a cyclical variation, which is quite different, because most of the time the pressure variations don't get transmitted to the arteriolas as well as the capillary bed. However, when the autoregulation is lost, what they found is the pulsatile flow is getting transmitted to even the capillary level, and there is no compensatory mechanism. So there is a cyclical flow difference even during a cardiac cycle. So all this was found. In addition, they found 3 different patterns of spinal cord blood flow in patients having traumatic spinal cord injury. So the first image, in this array, the first column represents the images, the radiological images. The second is the visualization post laminectomy and instrumentation, and the different blood pressures seen by laser spectral calorimetry. So the first case here you can see is a T6, almost T6 level injury at this thoracic level. And the post laminectomy, when they did a laser spectral imaging, what they found was, you can see there is an area of extensive low flow, followed by a slight penumbric zone here. And on augmentation of the blood pressure mapped to around 103, that is around raising by 30 millimeters of mercury, the penumbra area started increasing. That means that there is a lot more penumbric area which was there, which was initially not being perfused at a map of 70. And this is a typical necrosis penumbra pattern which we are anticipating. However, what was interesting was what they found in the second set of patients who had cervical spine injuries. So these patients who had injury at the cervical level, what they found was a hyperperfusion kind of spinal cord blood flow, wherein which even at a map of around 70, 68, 70, there was quite a lot of hyperperfusion. The blood flow was quite high. And as you can see, even at, and it kind of even increased at a higher map, which is expected. So this was quite different and was unanticipated by even the investigators. And so this should be kept in mind, because augmenting the blood pressure in these subset of patients where there is already a hyperperfusion can further worsen the cord edema, as well as can give rise to local hematomas as well at the spinal cord level. And the third was again the patchy perfusion. So that is again seen in like thoracolumbar spine cord injuries, wherein which there is a patchy circulation, wherein there are areas of like patchy necrosis bar low flow intermixed with higher blood flows. So these were the three different patterns which were there. So you cannot like individualize like what to expect in any subgroup unless you evaluate them individually. So why there is not much of a study into the spinal cord blood flow and spinal cord perfusion pressure? It's kind of analogous with the traumatic brain injury. As we all know that in traumatic brain injury, there are two key parameters, that is the intracranial pressure as well as the cerebral perfusion pressure, which is key to the management. But the crux here is we can measure the ICP. So your CPP is MAP minus ICP. However, in spinal cord injuries, we lack the eyesight into the spinal cord pressures, because even now there are only very few centers which record the spinal cord or the intraspinal pressures at that level. And this led to the lacunae, and that is why there is a lot of lacunae in the literature regarding the spinal cord pressure monitoring, and there's a lot of arbitrary guidelines. So coming to monitoring of spinal cord pressure, it's been shown that it's quite safe, and the Codman pressure probes which are being used for the traumatic brain injury, the same probes are being used here also. And in scenarios where the patient is undergoing a laminectomy and open instrumentation, the Codman probes are inserted, and it's inserted. The durotomy is done 1 or 2 levels below, and the probe is positioned at the level of the injured cord, and it comes out through the side like you can see here, and it's being transduced continuously to monitor the spinal cord pressures. So study by Isaac Fang, they're supposed to be the pioneers on spinal cord pressure monitoring and evaluation. So way back in 2016 itself, they did the studies and they commented on the safety profile as well as the probe placement and regarding the accuracy of intraspinal pressure monitoring. And they found that the pressure monitoring done by Codman sensors were quite satisfactory. And it is safe to keep these probes in place in situ for at least 1 week from the time of insertion. So coming to spinal cord pressures, just like our ICP, it has 3 waveforms, the P1, P2, and the P3. And as you can see, as the pressures go high, the P2 peaks. And based on this, you can always get the spinal cord perfusion pressure, that is MAP minus ICP. So this is a more accurate measure of cord perfusion as compared to an arbitrary MAP, which we are choosing. And rather, all the clinicians should aim to optimize the spinal cord perfusion pressure rather than the MAP. So that is the first step we should take towards individualized patient management. So coming to optimal spinal cord perfusion. So now we have the ISP probe in situ, we have the arterial line, and we get the spinal cord perfusion pressure. So just like how we choose a CPP optimum, that is optimum CPP, we choose a spinal cord perfusion pressure, which is optimum. So it's basically plotted against the pressure reactivity index. As we all know, it's called as so the pressure reactivity index, wherein which the it studies the it gives us an idea about the autoregulatory status of the field. So if the autoregulation is not intact, as if we increase the blood pressure, there will be a concomitant increase in the pressures, the ISP, because it is causing more volume and the more edema and more pressure is going up. So there is a positive correlation. Whereas if the autoregulation is intact, there will be a negative correlation. As we increase the blood pressure, the pressure should come down, just like in the brain. So based on this, Samira and her colleagues, they had reviewed an article based on targeted perfusion therapy in spinal cord trauma. And they found that studies which had used spinal cord perfusion pressure, and they based on the pressure reactivity index, how they evaluated the perfusion, how they guided the perfusion therapy. So as you can see here, it's a color-coded imaging which comes in your monitor. So it basically gives you an idea about the pressure reactivity index of the individual patient as it plots the intraspinal pressure as well as the cerebral spinal cord perfusion pressure, and it gives you color-coded for ease of seeing and ease of understanding. The red area is an area where there is a positive correlation, wherein which if you increase the blood pressure, the intraspinal pressure is also going up, and the green zone is where the PRX is negative. That is, as you increase the pressure and we keep the pressure in this area, the intraspinal pressure is low. So the black line here represents the patient's intraspinal pressure, and that is what we should guide. We should try to keep the cerebral cords, the spinal cord perfusion pressure in the zone between the two areas where the pressure reactivity index is positive. So in this patient, the optimal zone is around between 60 to 90. So that is what we should aim in these kind of patients. Now next is, there are so many centers where they use a lumbar drain and they transduce a lumbar drain and take it as a surrogate for spinal cord pressures. So studies have shown that the spinal cord, the fluid column which we are transducing is non-pulsatile and for almost like 1/5 of the time. And as you can see here by the image, when there is an injured cord and the CSF is below, we are putting a lumbar drain, there's hardly any pressure which gets transmitted to this fluid column. So it does not equate in these kind of scenarios. It helps only when there is a column of CSF around the injured cord. And these scenarios, the intraspinal pressure as well as the CSF pressures kind of correlate. So essentially, why I told this is we should always try and put an intraspinal pressure monitor if it is available rather than bank on a CSF pressure. So therapy is based on ISP monitoring. The goal was to reduce ISP and increase the spinal cord perfusion pressure. So just like TBI, a lot of these things have been studied on traumatic spinal cord injury as well. However, there are only two scenarios, two interventions which kind of increase the spinal cord perfusion pressure as well as reduce the ISP. One was the pharmacological, that is by increasing the blood pressure with vasopressor, and the other one was surgical decompression. So, study by Melissa and colleagues they studied the spinal cord perfusion pressure in patients with acute spinal cord injury in critical care unit. And what they found was the only non-surgical technique to reliably increase the spinal cord perfusion pressure was to increase the MAP. So, but the question remains how to increase how much of the MAP should be increased, which again brings us back to the PRX as well as the monitoring of spinal cord perfusion pressure. And study by again Samira. So they did an outcome analysis. They wanted to do an outcome analysis of patients who had individualized therapy based on guided by spinal cord intraspinal pressure as well as spinal cord perfusion pressure. And they studied the outcome at the end of 1 year. And what they found is as a intraspinal pressures was low in the patients who had a lower intraspinal pressure. The improvement in the ASIA scores by 1, which is denoted by the blue column, and the ASIA score increased by 2 at the end of 1 year, which is denoted by red, is higher as the intraspinal pressures were kept lower. And even in patients in whom the spinal cord perfusion pressure was kept above 90, as you can see here, these patients had a higher rate conversion of ASIA scores at the end of 1 year. So, which shows that individualized blood pressure therapy is the key to improving the neurological outcome after traumatic spinal cord injury. Again, coming to surgical decompression, that also plays a very vital role in ensuring that our spinal cord perfusion pressure is maintained at the optimal level. So this study was done where they did an expansion duroplasty in addition to laminectomy. So they compared the difference between the conventional laminectomy which is being done and the additional duroplasty which was done in the subset of patients. So they randomized 2 groups. One had only laminectomy and one had an additional duroplasty. And what they found was the duroplasty group had a lower intraspinal pressure, as you can see across timeline, even up to 10 days after the procedure. And they, if you compare the spinal cord perfusion pressure, the patients who underwent duroplasty had a higher spinal cord perfusion pressure as compared to patients who had only underwent laminectomy. So what they concluded was duroplasty increases spinal cord perfusion pressure by approximately 15 millimeters or mercury more. And it takes only an additional 15 minutes for the surgeon to do a expansion duroplasty. And they also studied the complications associated with and the incidence of dural leak, which was one of the dreaded complications by the surgeons, limiting them from doing this. It was around 1 to 2% in their study. Now, again, coming to nursing care, I just want to briefly comment that monitoring of the spinal cord perfusion pressure actually brought an eye-opening to even the nursing care, wherein which what they found is, as we all know, these patients involve a lot of turning around to avoid the decubitus ulcers. And what they found was even the turning as well as even lying down supine for a long time on a rigid surface post laminectomy increases the intraspinal pressures, because post laminectomy what they found is in the injured cord, the level at which the injury is, the CSF column is not there, which is actually acting as a shock absorber in a normal scenario. However, in these patients, the CSF column is not there. So all the pressures are getting transmitted to the spinal cord. So what they concluded was this all could give rise to potential cord damage. So one of the suggestions what they had found was to avoid keeping a pillow because between the shoulders, especially in patients who are undergoing mid-thoracic level instrumentation and laminectomy. It's always better to avoid keeping anything rigid, such as you can see here, they keep rigid rods or columns along the to provide more support to the spinal cord, which is actually causing more damage than good. Now coming to multimodality monitoring, that is now what is the new kid on the block. So this is a conventional triple bolt which is being used in neurocritical care units across United Kingdom. So it's a part of the Boost 3 trial. So here there are three probes, one measuring the ICP, one the brain tissue oxygenation, and one is a microdialysis catheter. So the same thing was put in patients who are undergoing laminectomy, and instead of the ICP probe only, they had put the triple bolt there quite successfully, so as to get details about the metabolic profile of these patients. And what they concluded was, again, the group by Isaac Fang, what they concluded was the microdialysis monitoring, the additional triple bolt did not cause any serious complications. And they justified keeping a higher spinal cord perfusion pressure of around 90 to 100 millimeters of mercury, and to keep the tissue glucose level more than 4.5 millimoles. And these minimize the metabolic damage at the injury site. And also what they found was, they also measured the drug concentration at the level of spinal cord, especially the steroids. So what they found was the penetration of IV dexamethasone, which was given to these patients, increased by threefold when they increased the spinal cord perfusion pressure by 10 millimeters of mercury. So this could be one of the reasons why most of the drug trials in these scenarios are failing, because the drug is often given in a suboptimal condition, which is limiting its penetration to the injured cord. So what is the future? The future is we have to individualize the therapy. We cannot generalize the based on a map or this one. It should be more individualized, just like how we manage our traumatic brain injured patients. And hopefully in the future, there will be probes which are specifically made for monitoring spinal cord pressures, and which we can put without surgery. Like now it has to be inserted in patients only who are undergoing open laminectomies. So we can have a percutaneous insertion, just like how we put for brain injured patients, it would be good. And the application of these concepts will give rise to new guidelines as well as new therapeutic models. Thank you very much.
Thanks, Dr. Ajay. You were well in time. And there's one question in the chat box. So just a second. I can't access the chat. Yeah. So one of the listeners want to ask, how does it translates to the outcome of such patients after monitoring to this much extent?
Yeah, so that is what actually I think the question was asked when I was halfway through the presentation. So as you can see, so it makes a difference, as I already showed in my slide. The outcome benefit is there when you individualize the therapy based on the spinal cord perfusion pressure targets as well as the ISP. So if we, rather than keeping a map of more than 80 in all patients, or 80 or 90, an arbitrary target, we should individualize. And then what they found was the Asia scores even improved up to 2 in scenarios where the spinal cord perfusion pressure was kept more than 90 in certain group of patients, which normally we will not do because we don't have the monitors, because we will keep the map at around 80 and we'll think, okay, that's what we should be doing. So, and again, we cannot keep a higher map of 80 or 100 blindly, because as I showed, there can be hyperperfusion scenarios which can further worsen the cord edema. So in that condition, it could be disastrous, keeping a higher blood pressure. And if we have the intraspinal pressure monitor, we know that, okay, the pressure reactivity index is positive. So we should not again hide the blood pressure because there's no autoregulation. It's going to do more damage. And if it is negative, yes, as well go ahead and increase. And we can see the ISP is getting reduced as well as the cord is being perfused. So yes, the monitoring does have its outcome benefits, but it's still being explored.
Dr. Ajay, I also have a question for you. What are the other factors other than maintaining the spinal cord perfusion that help in, are there new advancements for spinal cord protection other than maintaining the perfusion?
Yeah, so today's my lecture was quite limited to spinal cord perfusion. That is why I commented only on that. As you can see, like it's mainly the as I commented earlier, there are only few therapeutics which are like which have given an outcome benefit. So one of the main things which actually has given, other than the pharmacological, is the blood pressure. The pharmacological, again, as you know, based on the NASA's trial, there is always a lot of controversy regarding steroids, and there is currently no role. And then again, there is something with pluripotent cells and a lot of therapies or stem cell therapy and all is happening. But that needs to be explored in detail, because these are all individual institution-based practices which have shown some amount of benefit. However, there is no guidelines or anything which has shown a clear-cut evidence that, okay, it's going to translate into an outcome. However, this is something which we can do during the initial part of the injury. So we can limit the injury rather than repair the injury. So controlling the blood pressure, reducing the spinal cord pressure is something which we can do and limit the injury rather than go ahead and try to explore, okay, what can be done now there is an injury. So which is usually all these therapies kick in after weeks or months.
Does it decrease the incidence of surgical intervention, or it is just an additional thing?
No, it does not. Surgical intervention, like I said, is the one of the definitive things which is known to reduce the which is known to improve the neurological outcome. So other than the surgical intervention, the other two things which has now shown promising results is the control of blood pressure as well as the spinal cord pressure. Any other questions?
Thanks, Dr. Ajay. We don't have any questions. Now I'll invite Dr. Gaurav Singh Tomar, who is consultant in charge, Department of Critical Care, Indian Spinal Injury Center, Vasant Kunj. He'll be discussing rehabilitation of a spine injured patient. Dr. Gaurav, over to you.
Thank you, madam. Good evening, all of you, and happy Teachers' Day from my end to all the respected faculty. So to start with the last presentation of the day on this special spinal cord injury day, rehabilitation of a spinal cord injured patient. So my center, I work at Indian Spinal Injury Center. We are dedicated in catering services for such kind of patients, those who are coming to us with a acute trauma related with the spinal cord. We deal in acute emergencies, and also we follow them up to the long period, because we also cater services in rehabilitation. So we deal with the patients worldwide at our center, and we do really good job in rehabilitating them to lead them to a good life thereafter. So to start with, having a small overview, we already discussed about it. Spinal cord injury is a term used to refer the damage to the spinal cord resulting from the trauma or from the disease or degeneration, such as cancer. So spinal cord injury with its resultant paralysis is one of the most devastating medical condition of the public health importance that we need to take care of. So coming to neurological manifestations, we already discussed that it may present with a spinal shock within a first week. It results from the abrupt withdrawal of connections between the higher center and the spinal cord, characterized by the absence of all the reflex activity, flaccidity, and loss of sensation below the level of lesion. Motor sensory impairment, it includes neurological level, completeness of the lesion and symmetry of the lesion, and presence or absence of the sacral sparing or root escape. After that, we may deal with the spasticity of the limbs in such cases, because it's result from disconnection of intact reflex arc from CNS controls. So it's characterized by either the hypertonicity or hyperactive stretched reflexes and the clonus. It typically occurs below the level of lesion after the initial phase of spinal shock is over. So there is a gradual increase in spasticity, and also increased by the multiple internal external stimuli. Environmental factors like temperature and clothing can also impact and leading to spasticity, and also the external factor like urinary tract infection or bladder stones can also lead to this scenario. So how the neurology behaves in such patient? It may present with monoplegia. The level is in the lumbar region. It may present with hemiplegia, diplegia, particularly in a central cord syndrome, paraplegia, particularly dealing with the lower cervical or dorsal lesion, quadriplegia, and a higher cervical lesions or injury. Coming to the main topic, rehabilitation. So spinal cord injury treatment and rehabilitation is focused on aggressively working with the patient physically and psychologically. So basically it's a holistic approach rather than a one specialty job. We need to come up as a team when we deal with a cervical cord injury, because itself is a complicated matter, and as a disease is lead to very detrimental outcomes. So in a short period of time, patient can maximize their neurological recovery and general health. So basic treatment include the following: slow, sustained passive stretching and active stretching whenever possible, teaching correct positioning to caregivers and relatives, facilitating antagonist active movements, inhibiting the synergy pattern, weight-bearing exercises, use of ice to reduce spasticity and facilitate voluntary control thereafter. So this is our rehabilitation center at ISIC Delhi. So just to break down this topic in a different compartment, first dealing with the cardiovascular impairment. A rostral spinal cord injury will result in a loss of sympathetic communication between the brainstem and the heart. That's a crosstalk between the brain and heart, whilst parasympathetic input remain intact. So it's a kind of overactivity of parasympathetic system over the sympathetic system. So because subsequently that lead to bradycardia and the pooling of the blood vessel peripherally. And usually we have also noticed the orthostatic hypotension is particularly common in a spinal cord injury level above the level of D6, 6th thoracic vertebra. So it's very common. So we need to go very gradual while rehabilitating such patients. And to minimize these effects when mobilizing patient early after spinal cord injury, the cardiovascular system should be allowed to adopt gradually by a slow progression to the vertical position. This frequently begins with the elevation of the head of the bed and progresses to the reclining wheelchair with the elevating leg rest and the use of tilt table. So we should not be very aggressive in an initial phase after the surgery part is over or the acute phase is over. So it should be very gradual. We should start step by step. And this is just in brief what clinical manifestation we see when the level of injury is very high at the level of C1 and C2. So particularly what we see in a higher cervical injury patient, they are usually ventilator dependent. So they require assistance in airway clearance, and most of the time they are ventilator dependent. So in such cases, we usually go for early tracheostomy so that they can wean off early. And in long term, a phrenic nerve stimulation is also required to have their own breathing efforts. Coming to C3C4 level, an acute stage recovery will require mechanical ventilation support with recovery and training, likely able to breathe on their own. So they are also partly kind of ventilator dependent, particularly the C3 level injury. And they also require a kind of tracheostomy for long term. And lower cervical injury patients, they usually have the weak cuff as high cervical injury patient, and also they poses with a paradoxical breathing pattern. So we have a different kind of rehabilitation for such patients. And coming to the upper dorsal injured patient, they may have weak cuff because they involve some intercostal muscle and erector spinae muscles. Lower dorsal, they significantly have decreased expiratory efficiency. They do have decreased cuff effectiveness and ability to expel secretion in some patients, not all patients. Most of the time, dorsal injury patients don't pose much challenge to us because they, with the rehab, they do well and they go home early. So cardiopulmonary assessment, we focus on history taking, inspection, palpation, percussion, auscultation, and also we also observe the chest exertion with the help of tape measurement. Vital capacity is an important part, and that we measure with the help of handheld spirometer. Particularly in a high cervical lesion above the C3, it's usually less than 25%, and in a mid cervical like C3, C4, C4, 25 to 50% of the normal vital capacity. In lower cervical is 50 to 75%, and in mid and lower thoracic lesion is 70 to 80%. And after that, the cuff function, we usually observe for cuff reflex, functional cuff, whether it's a weak or moderate or non-functional. And also we go for a special test like respiratory muscle strength test, peak with the help of peak flow meter or PI max or peak expiratory maximum flow. And also the endurance test, some maximal exercise testing. So coming to the management part, we have the primary goals of improved ventilation in such cases. And also we do work on to produce the effective cuff so that they can clear up their tracheobronchial secretions. And we also do work on preventing the chest tightness that usually these patients may come up with. And also we need to work on their abnormal, shallow or paradoxical breathing pattern. So in the ICU, in acute phase, we start with the positioning and the percussion. So this is how the Trendelenburg, steam Trendelenburg, we start with the general physiotherapy percussion part and the tilt table. So this is very gradual. We should not start with the extremely with the high tilt table because they may present with orthostatic hypotension, and patient may have bradycardia and severe hypotension. That may lead to cardiac arrest also. So we need to be go very gradual while dealing with rehab of such particularly cervical injured patient. So we should start with the head elevation first, then also support their leg and part, and then gradually we go up. So coming to the neurophysiological facilitation of respiration. So neurophysiological facilitation involves the spatial proprioceptive or tactile stimulation, and particularly quadriplegic patients that stimulate their own respirations. So that involves the placing the finger in between nose and upper lip and apply a moderate pressure, and also involve that's called the perioral. It's called the perioral stimulation. Another is thoracic vertebral pressure, where the pressure is applied below the ribs down to the ribs in the intercostal muscle region that stimulates the respiratory muscle to act part in it. And another is the basal lift, where the pressure is applied below the transverse process of cervical vertebra, cervical dorsal vertebra, and an intercostal stretch. Here is the intercostal stretch, and also the contraction of the abdominal muscles. So another method of giving them a rehab is the glossopharyngeal, or another term called for such is the frog breathing. So it's appropriate for patients with a high level cervical lesion who are dependent on mechanical ventilator, and as well as for patients with a high cervical lesion who are not dependent on mechanical ventilator. So in glossopharyngeal breathing is a frog breathing. We ask patient to have a gup kind of. We ask patient to engulf the air with the help of lip, facial muscle and throat muscles, so that just to have an activity of their own to increase the vital capacity in such patients. So that called the frog breathing. Breath stacking, another technique where a resuscitation bag is used with the mouthpiece or a face mask to deliver 2 or more breaths prior to the exhalation in order to augment lung volume and add in a secretion clearance. So another technique is the deep breathing exercise that we all know. I hope diaphragmatic breathing should be increased, not the abdominal part. To facilitate diaphragmatic movement and increase the vital capacity, the chest physiotherapist can apply light pressure during the both inspiration as well as expiration phase. So these are main 3. Another method is the air shift maneuver. So in which we ask the patient to have a deep inhalation followed by the glottis closure. So we ask patient to take a deep breath and just hold the breath for a period, for a particular period. We initially start with the low period, then gradually increase to particular time. So that help in mobilization of air to middle and lower part of the lungs, and that in with a period of time that increases the lung expansion and help in a better breathing pattern. So this technique increase the chest wall expansion and may cause but the problem is that this may cause the patient to hyperventilate also. So at the same time, we just motivate the patient to just have a very slow and deep breathing. Coming to the respiratory muscle strengthening, it improves the respiratory muscle strength and endurance. So there are 2 methods of handheld inspiratory muscle training devices. One is resistive, another is threshold trainer. Here are the 2 pictures that I'm talking about. Breathing through these devices increases the resistive or the threshold inspiratory load on the muscle. So that and subsequently lead to improving the pulmonary function, reducing the dyspnea, and also it improves the cuff functions. So another method is assisted cuff technique. So there are the few methods like claustrophrenic assist, where the therapist apply the pressure on the claustrophrenic angle. Another method is placing the patient in a prone position and with a head flexion, assisted cuff in a prone on elbow, extension and inspiratory phase. Another method is anterior chest compression assist, that and I hope in every ICU or what this used to be a very common method, and particularly in a tetraplegic self-assisted cuff in a long sitting. We make patient in a sitting position and ask them to have assisted cuff. Coming to particularly in a paraplegic patient, we also make them in a sitting position for a long duration, and just keeping the their hands below the head and ask them to inspire. So also in an expiration phase, we ask them to touch their knee with the head. So another effective method is the use of abdominal binder, because these patients have the primarily abdominal breathing patterns. So to increase the diaphragmatic breathing, we just apply the abdominal binder so that their thoracic breathing pattern function improves. So this improves the respiratory function and cough ability in patient with a high thoracic and cervical lesion. It may improve the respiratory mechanics by compensating for the non-functioning abdominal muscles. In addition, these also provide the secondary benefit of maintaining intrathoracic pressure and decreasing the postural hypotension. So this has an advantage of decreasing the risk of postural hypotension also. So we also go by this binder in high cervical or high thoracic patients. Another method is the use of insufflator or exsufflator device that we have with us. And with the use of this device, usually first we apply during inspiration, and then this has automatic mechanism of giving the first airflow during the inspiration, and then have a kind of suction during the expiration phase. So that stimulate patient to have a initiating the cough. So another way is the cough assist device. So last but not least way is the diaphragmatic stimulation. So it's a very, I would say, very less practice method of initiating the patient to have their own breath. So diaphragmatic pacing involves implanting a battery powered system in the diaphragmatic muscles to help stimulate breathing. So, and there are very few centers which actually go for this method of diaphragmatic stimulation in cervical injured patient. We also have very less number of patients which we have in which we have placed the diaphragmatic stimulation, and also there is a learning curve, and putting it also, the results are also not, I would say, not very promising even after applying the diaphragmatic stimulator, and it's a very costly affair, I would say. So diaphragm pacing is a method to help improve breathing, speech, and quality of life of patient with a spinal cord injury. Coming to manual stretching, mobility and compliance of the thoracic wall can be facilitated by the manual stretching, chest wall, muscle, and the supine position. So again, we all know this is done by placing one hand around the side of the chest with the fingertips on the transfer process, and other hand on the top of the chest with the heel on the edge of the sternum. So this enhances the respiratory function in cervical injured patients. Coming to lung volume maintenance, intermittent positive pressure breathing via the mouthpiece or a face mask to support inspiration prior to the manually assist puffing can augment the lung volume, and also it increases the exhalation flow. So insufflation using the portable non-invasive ventilator or a insufflation device will also boost inspiratory volume prior to assisted coughing or insufflations. Coming to the next part, the musculoskeletal effects in such patient, we have seen patients to have muscle atrophy in such because of the crosstalk between the brain and muscular structure is hampered in such cases below the level of injury. There is the wasting and loss of muscles in such patient because of the denervation or the disuse atrophy. Another ways patient may develop the contracture resulting in deformity, and again is leading to difficulty with the functional mobility. Osteoporosis, osteopenia is very common in such patient because of the less mobilization, and fractures because of the osteoporosis, again subsequently that may lead to very fractures of the long bones. Overuse injury, this is something peculiar, but it does happen, particularly seen in a paraplegic patient because they usually come up with overactivity of their upper part of the body, particularly shoulder and the elbow. So for this, again, counseling of the patient is very required, very much required. Again, another complication that may face up with a heterotrophic ossification. It causes stiffness in the muscle or joint, which can lead to decreased range of motion, lack of movement and pain. Risk is highest in the first few months after spinal cord injury. Another complications that may we can see in such patients because of the postural change, due to the muscle atrophy, due to contracture, due to change in spine curvature. So another important part is, apart from the cardiovascular muscular strength, the cognitive effect, because we have seen many patients, because these are and conscious patients, those who are not able to move their limbs. So we have seen many patients, or almost all patients, which have the depression part actually, particularly with the high cervical patients. So study on cognitive percent individual have some form of cognitive impairment. That's a very big figure, and individuals with spinal cord injury are about 13 times more likely to experience cognitive impairment than able-bodied individuals. So they are at high risk for such things. So we should also come up, apart from the rehabilitation, this is also a part of rehabilitation program, and that require a special care. So while a spinal cord injury will not directly cause cognitive impairment, its secondary complication can influence your ability to focus and think clearly. Elevated levels of depressive mood state have been found in patients with chronic spinal cord injury, with the rates ranging from 19 to, and that can affect the cognitive function after spinal cord injury. These are emotional distress, sleep problems, poor cardiovascular health, their old age, or young age, or even medication, and increased sedentary behavior and social isolation because of their injury, because of their immobility, also the pain that they are not able to tell of. After that, neurophysiological assessment. A first neurophysiological neuropsychological screening was done using an MSC score for attention and assessment. We know that digit span test of the Vasular memory scale 3 for processing. Speed was assessed using mental control test of the Vasular memory scale 3 for memory visual memory test. So these are the various components of MSC. Above 24 and above is said to be the normal. Below that, we should take care of this. For learning and memory assessment, there's been Gluten's verbal learning test. For emotional status assessment, back depression inventory, state anxiety inventory. These are the tests that usually being done. So coming to the treatment of cognitive dysfunction in such patients. So behavioral therapy plays an important role in cases. So intervention that utilize the neuroplasticity to improve the cognitive function after spinal cord injury. The techniques that are most often used in cognitive behavioral therapy include the following 9 strategies. Cognitive restructuring or reframing, guided discovery, exposure therapy, journaling and thought records, activity scheduling and behavioral activation, behavioral experiment, relaxation and stress reduction technique. This is the most important one. Role playing and successive approximation. Coming to another important part in such rehabilitation of such patient, the bladder bowel management. So if the level of injury is, I would say, if it is above the level of D12, it usually result in a spastic bladder. If the level of injury is below the level of T12, it usually result in a flaccid bladder. So the reflexive bowel management include the establishing a routine diet and fluids. Digital rectal stimulation should be done in such cases. Pharmacological rectal stimulation with the help of water enema, suppository or microenema, oral laxative also plays the role. So this is an hyper kind of spastic bladder, I would say. And A-reflexes bowel management,
Sorry to interrupt.
establishing a
It's
routine.
already 8 o'clock. If you can be, little fast with the slides.
So coming with the A-reflex bowel management, non-conservative options like transanal irrigation, percutaneous endoscopy, colostomy. So these are the methods of bowel management. Bed mobility training is the first step toward the independence of patient of spinal cord injuries. Some important points are muscle strengthening exercises at the bedside, bed mobility exercises. So this is how the exercise is being done in such cases: rolling to the prone position, rolling to the side, rolling turn to the one side, segmental rolings that you all can appreciate in images. Prone extension, prone to quadruped positions. These are other methods of rehabilitating them to have their own movement. This is how we do at our centers, making them sit with the help of this uh, brace. So wheelchair functional training we do with the such patients to have their better cognitive outcome. Transfer training, wheelchair transfer training, how we transfer them to another, again wheelchair skill training, gait training, how to make them supine with the use of these braces, and how to make them stand and how to make them walk on a stair. Hydrotherapy again is an important thing that we also practices. And in a recent advanced high frequency chest wall oscillators, and for hand stabilization to prevent the contracture, there is a special gloves to prevent the hand spasticity. And electrical stimulation we also do for abdominal or phrenic nerve stimulations or abdominal wall stimulation to just have a better GI activity in such cases. Recent advances also include robotic exoskeleton system, water treadmill, and just in last but not the least, just a small video message from our Thank you for patience here.
Excellent talk, Dr. Gaurav. Indeed, you guys are doing a very good job. I'll request everyone to please switch on the videos and their microphones. Any comments or any inputs from any of the faculties or any of the participants, please? I would just like to add that I'm quite interested in, artificial intelligence. So in March or April, I think there was one discussion on the World Economic Forum where it was discussed that researchers have programmed the devices, like they are the nerve stimulation devices which have helped 3 patients swim, cycle, and walk. These devices, they send artificial signals to the specifically target and activate the regions of the spinal cord. So indeed, that's a great, I think a great discovery and great way forward to go in the spinal cord injury?
I say still we are in a very early phase, still after so many years. So still there is a long way to go ahead in this field, and there's a lot more, I would say, to yet to come up, and yet to come up with a better outcome in such cases. So just keeping our finger crossed to have a better outcome, and just to have a say, I would say thank you, Dr. Himanshu, for giving me this opportunity to have a talk.
I think, yeah, it was an excellent session, and thanks, Dr. Ashima, for so effectively moderating this entire session. Gunshan, Rishi, and Gaurav, excellent presentation, and especially to Gaurav, I would say your last video was it actually summed up the whole thing. That's what we wanted to convey through this World Spinal Cord Injury Day. So I think that was a great input from your side. And thanks to all the speakers. Thank you so much.
Thank you, sir. Thank you all.
So Ashima,
So-
should we end the session now?
Yeah, we should end the session. Over to Faraz to clear up the things.
Faraz, are there any questions in the chat box? If there are no,
No, sir. We haven't received any question from the participants, sir.
okay. So I think we should end the session now. Thank you so much.
Okay, sir.
Good
And
night.
thank you so much, sir. I want to thank each and everyone for being on our platform, ClearNet, sir. And thank you so much, everyone, for sharing the knowledge and giving your precious time. And with all your permission, we are closing here.
Sure. Thank you.
Okay, thank you.
Thank you and good night.
Good night.